afternoon, everybody. I'm Jaco Stokes from National Department of Health, Directorate of Affordable Medicines. I'm the Deputy Director, responsible for supply performance management and availability monitoring.
Good afternoon, everybody. Thank you for joining us for the performance dashboard last presentation before we go back up. I'm Bashir Inus, and I'm with the Global Health Supply Chain Program, supporting the National Department of Health with the supply chain reforms. And today we're going to take you through just a few of, or we're going to take you through a bit of a story in terms of the dashboards that we currently use to monitor performance across the Department of Health, specifically the Affordable Medicines Directorate. So we're going to give you a brief introduction, but then we just want to take you through all the way from medicine all the way down to a patient level, what we are currently monitoring, and some of the things that we're putting in place in terms of a future state of how we can get smarter about monitoring availability for our patients. So just to start off, I think it would be wise for us to just realize and just memorize for those who are South African what the mission of the Department of Health is. It's to have a long and healthy life for all South Africans. And the mission, of course, is to improve the health status through the prevention of illness and the promotion of healthy lifestyles, and to consistently improve the health delivery system, which is where we are a lot involved, by focusing on access, equity, efficiency, quality, and sustainability. So there are a lot of reforms that are currently taking place at the National Department of Health. Areas that involves technology, different ways of getting medicines to patients, promoting the rational use of medicines, enhancing the selection process, building those, the word they used was mini control towers in provincial levels. But what we're going to be concentrating on here is just improving the visibility and analytics. So we'll start off with the essential medicines application. Gavin, when he spoke this morning, he spoke about the application of how we have all our standard treatment guidelines and our essential medicines on a specific application at the moment. And what that allows you at a National Department of Health level is that now we can actually start monitoring who's downloading these applications. When I worked as a pharmacist at a facility level, we had all these books in our hands and we had to look up what the different standard treatment guidelines were. Now it's available on your cell phone. And at National, there's a lot of data that you can actually use that comes out of that. And some of the data that we're using is to see that most of the users that are actually using the application are looking at hypertension. They're looking at tonsillitis, pneumonia. We know what diseases sort of areas they're looking at. But we're also looking in terms of when doctors or any type of healthcare professional are trying to maybe deal with pediatrics, that they are specifically looking up the pediatric dosages for amoxicillin. So that makes us understand what are the type of things that our health facility people are looking at. Also, what medicines are they looking up? They're looking up amoxicillin, abacavir, acyclovir. These are the products they're looking up. But also, from a monitoring perspective on how many people are downloading this tool, we know where the people are downloading within the country of South Africa, in the different provinces, but also outside of South Africa. And how, when we have strategic interventions, for example, we go on a roadshow to the different pharmacy schools, and we end up with a spike like this, where you can see that when you go to the schools, all the students are suddenly downloading it, and we have a huge spike. And then when we go and do another intervention or another sort of marketing thing, then you'll see another spike here and there. We also then have a good understanding of how much time people are spending on the application. So if they're looking up hypertension, are they spending 3-4 minutes on there? Or they're just browsing up and down here and there? And this helps a lot in terms of understanding who's actually downloading it, where they're downloading it from, and what they're using it for. I'm going to give over to Jaco now from the National Department of Health. And we're going to take you through a journey now from all the way from supplier management all the way down to facility level and how we're trying to monitor medicine availability and stockouts. Oh, you don't need that. Thanks.
Okay, basically from my side, the function that kicks in for my team is looking at your supply performance management and the various tools that we basically use to actually achieve that. This is a post-contract award function. We have about 1,140 items, line items that we look at between 85 suppliers across 13 pharmaceutical contracts. Over the past few years, we've put in place various tools that actually assist us in this regard. The first one here is the supply performance management tool, looking at visibility in terms of, for instance, inception of a contract up until the end of the actual deliveries and order situation from the various suppliers. They report on this on a monthly basis, and there's scorecards and monitoring systems in place to actually monitor the supplier's performance in terms of that. One other tool is the pipeline analysis on a fortnightly basis, looking at the total supplier situation. Okay, their stock holding, their actual orders that they have in the system, and their production plans, and also giving us an indication from their side on actual problems that might exist in the system. And then the last one, as Gavin has indicated, suppliers are not banks. So in terms of the general conditions of contract, provinces are supposed to pay their accounts within 30 days. And this is also, from a supplier point of view, what they actually give us on a monthly basis to actually try and achieve that. As I said, there's various scorecards. The criteria that we use to measure suppliers on is lead time. In general, that's about 14 days. Completeness of an order, or OTIF, on time and in full delivery, trying to prevent this administrative burden on various multiple orders. We engage with the suppliers regularly, once a quarter at least, with each supplier face to face, trying to work on their production plans going forward in relation to the actual demand plans. We do the debt analysis and then the reporting, as I've indicated. This is just one of the dashboards that we use during our meetings, specifically related to a supplier. Looking at, I must actually stand on this side because I cannot see what's on that thing. Looking at their total picture across what was happening, the reporting dates, what did they actually deliver, to which provinces, where did most of the stock actually go. Then also looking at your original order quantity versus your orders, trying to see if your demand actually matches what's happening physically. And then this is just a picture of the actual irrational or rationality of orders received. We try and level this out to that kind of picture, but you see that there's quite an erratic ordering pattern from various participating authorities. Overall supplier performance, one of the dashboards that we get on a monthly basis that we discussed with the suppliers at the various meetings, looking at your submission of your monthly data by the supplier. There you will see December was quite bad, and that's usually explainable in relation to we've instituted a validation rule in terms of the reporting. So a lot of the suppliers had to actually go back to previous data to actually get data into the system. It looks quite better for January, February, after they've actually come on board. Then lead time compliance and your OTIF. I'm running through this. We can discuss it at a later stage during the break further. One of the tools that we use is your pipeline analysis. As I said, they report fortnightly on this. What I want to explain here, there's three pills here. The blue one, what that means is there's sufficient stock on hand, and we look at stock on hand in terms of actual physical stock that they have, what is in QC, and what are they planning to produce in that specific month, and that outweighs the actual orders in the system. Then we look at the brown stuff, and the brown stuff is brown stuff. Okay, we're in trouble there. So the actual stock on hand and the demand actually outweighs that. And then the purple one, what Gavin used a term, I don't know what that term is, but purple means that there's a problem. Okay, maybe across South Africa, in all of the provinces, there might be an API problem or whatever in terms of that supply. And that's a thing that my team kicks in when you look at the brown and purples and trying to resolve that and ensure security of supply. One of the things is your top focus items that is highlighted. I'm specifically referring to the top one here, nystatin. I'm going to refer to the slide later on. There's a problem with that, and we know what the problem is. It's a supply problem currently. But going forward, we'll explain this. And then your supplier age analysis, looking at the provincial picture in terms of debt as reported by the supplier. We also look at the various suppliers. How does the country situation look like? And then accounts older than 30 days. The process that follows from this is that it's being escalated to the department, the DG, the Director General, which then takes it up with the heads of health or heads of departments in the provinces. And we're trying to resolve the actual debt. With suppliers, as I said, they are not banks. And then provincial stock out dashboards. This is a recent dashboard that we've started. We receive stock out reports from the provinces. We consolidate it. We've put it into a dashboard currently where we look at the provinces that actually report on this, the items that is problematic, and here you will see the nystatin again is across the 4 provinces that actually report it. It's a problem across all of that. And yes, then I'm going to hand over to Bash.
Sure. Okay. So Jaco, of course, took us through the suppliers and the provincial warehouse levels. What I'm going to be taking you through now is the 2 levels lower than that, and that's our hospitals and our facilities, of course. And I think one thing we need to just sort of just tell everybody here is that there are different interventions at different levels of maturity, right? So some data is automated, sitting on a server. We can just pull it. That's great. Some systems are very old. We're getting it on Excel. We're trying to clean it up, making sure that we can make sense out of the data and then use that going forward. Gavin also brought up a very important point around master data. You know, if we have 1,200 products on our master procurement catalog, yet, for example, at a warehouse level, we might have 20 versions of paracetamol, which is the same product, right? So there's a lot of work that's been done in terms of cleansing the data to get to a point that we're speaking the same language. So if paracetamol is 1, 2, 3, 4 at a supply level, it's the same at a warehouse, it's the same at a hospital, it's the same at a facility. And a lot of work's being done around that. So in terms of a hospital dashboard, I'm not going to take you through everything. Like I said, there's been the development of an electronic stock management system at the various hospitals around the country. Some are automated and go via centralized servers. Some we receive manually via Excel. Some go via FTP site. But what we do is that we monitor the availability of medicines. We have green, which is great, anything over 90. We have the orange, which is between 80 and 90. And anything under 80 is red, right? The purple over here means we haven't received data in over 30 days. And that's one of the things that's key for us to monitor, because there's no point having 100% availability, but the last time you checked it was the 23rd of April 2016, because that's not a fair reflection of what's going on. So those are some of the things that we put in place in terms of when we monitor to make sure that there's constant data coming in, and we'll be monitoring, and if anything is not green, how does Jaco and his team address this? What we're also working on is that this is just a different view of the same dashboard of the 10 central hospitals of our country. These are the biggest hospitals within South Africa, and a lot of our patients go through these facilities. But what are we working towards is not these snapshots that we just currently have that we're putting on a wall, but to actually interact with the dashboards and make a lot more meaningful decisions and getting out of that static environment and more into a live type environment. And some of the things that we're working is, for example, if you have Steve Biko right over here, and that's a hyperlink, you click on there, It gives you all the information now related to Steve Biko Hospital, and you'll be able to monitor the availability at the hospital level. You'll also be able to split that between vital, essential, and necessary. There are 11 products that are out of stock. Over here, this blank over here is being able to link your products to budgets. So if you have a budget for a facility, how much money are you spending on that, and how is that linked back to your budget? Also, you now be able to monitor your stock on hand as well. So different interventions have different levels of maturity and different levels of detail that's available to you. Some fields are more than others. Sometimes you only get stock availability, and that's good enough, because one of the key things is to increase access and avoid stockouts. But of course, as we get more information, we can make more meaningful decisions from there. And then most importantly, like Jaco spoke about, is now be able to triangulate and correlate the different levels of detail that we have. We saw nystatin was out of stock at a supplier level. We saw nystatin was out of stock at the depot. We can see at the hospital, nystatin's out of stock here as well. And now he has a better indication that when he has his weekly board rounds with his team and with the rest of the affordable medicines team, they now know exactly which items they need to action to ensure that these products get sorted out immediately. Primary healthcare. Some people may have gone to the demonstration on the primary healthcare dashboard. But of course, what we use the primary healthcare application at facility level for is to monitor stock availability. So we look at the antiretrovirals, the TB and vaccines. Some facilities, of course, going to work towards adding more products to this list. But what we do is we monitor the top products that are out of stock. We monitor that the facilities, of course, reporting on a weekly basis, for example, every Thursday that they're supposed to be reporting, and also the compliance to what they're supposed to be reporting on. If you're supposed to be reporting on 80 products, are you actually reporting on 80, or are you just doing one of each to make it look like you're complying? So, and it's not about, being able to it's about keeping the people accountable, making them feel involved. Unfortunately, what we haven't done and what we are working on is the ability to disseminate this information from a national level to provinces, to districts, and to facilities. Because once people are involved, once people see the value, it's much easier to get the buy-in and to make this work. So pulling it all together. Jaco, you want me to do this one? Okay. Okay, so proactive triangulation, right? All this means is that we're not yet completely there, right? But this was the normal day and life of the Affordable Medicines Directorate. The erratic ordering that goes on a daily basis. This is a cholesterol tablet that is for chronic stable patients. And we should never see such erratic ordering by 5 of the provinces for this product. So one of the goals that we have, of course, is to stop this. It's that if it's a stable product, we need to be able to get that line so much closer together, because it's so much easier to forecast for such products, and hence also be able to tell our suppliers that this is actually the amount you should be producing on a quarterly basis. So this is specifically what we're trying to fix. And we've been very successful in a lot of areas, but there's still, of course, a lot of room for improvement as well. And of course, bringing it all together. Jaco spoke about the board round. Every Monday, Khadija, Gavin, Jaco and his team, they sit, they look at the different sources available, from the supplier dashboard to the hospital, to the provinces, to primary healthcare, and they look at what are the key products for them to action on a weekly basis to avoid stockouts, right? If things actually get down to this primary healthcare level, that is our last signal available in terms of avoiding a stockout. Hopefully we can address it right at the supplier point so we can avoid anything that goes further down. But sometimes you don't get it right, but you can hopefully try and avoid it and catch it here, or even catch it right at the lowest level if you need to. Then the Central Chronic Medicines Delivery and Distribution Program. I see a few colleagues sitting here who's very much part of that program. A lot of the things that we do are related to performance KPIs. This dashboard specifically is more on a reporting level. There's definitely a lot of room for improvement in relation to this, and how we can actually relate it to rational medicine use. We have over 1 million patients on this program. We have an X amount of patients on antiretrovirals, an X amount of patients on type 2 diabetes, hypertension. Is there rational medicine use that's taking place there or not? Currently, we're just using it as a reporting tool, and we're looking at the different districts involved and how many patients have been recruited per district within South Africa. We're also just monitoring currently the amount of pickup points in registered patients. So for example, pickup points is specifically public sector and private sector. How much options does our patients have available? If it's closer for the patient to go to a private pharmacy down the road, that should be an option for that patient. And if it's after hours, even better for him that he can go to that private pickup point. So I'm not going to go into too much detail around this, but this is just specifically on reporting and not so much on performance in terms of monitoring that program. Pharmaceutical services. So we have a head of pharmaceutical services in every province of the country, 9 provinces, and they come up on a quarterly basis. And they are monitored against specific KPIs that they need to deliver against. So every quarter when they meet at what they call the HOPS meeting, they are monitored against these KPIs. And this is just how we interact with the provinces to make sure that everyone's aligned. And then just the van specifically. So we know that the van is more than dashboards. It's the processes, it's the people, the policy, the technology. It's everything, right? It's not only the dashboards. And therefore, a lot of the reforms that are currently taking place is how to implement this operating model, office forecasting, demand planning, distribution planning, and then, of course, incorporating the continuous improvement in the dashboards. So that's where we are at the moment. In terms of a future state, I have Stuart sitting right here, and he's the sort of mastermind behind our ICT reforms for the National Department of Health. So this is a very messy diagram over here. It looks like a lot of things, but this is just our current as-is ICT landscape in terms of us understanding exactly what data sources are out there and which are the key ones for us to look at and ensure interoperability so that we can actually make sense that over the next 5 or 10 years, which systems needs to be speaking to each other and how we're going to link them all up. Doesn't mean we're there yet, but these are the systems that we need to be looking at, and these are the ones that need to be talking to each other. In terms of performance dashboards specifically, I've showed you snapshots of everything, right? But we really need to move to the ability to drop and drag and help the people to see and understand the data. We want to make much more proactive decisions, and what we're currently going to be sort of deploying in the next month or two, actually more like 2 or 3 months, and within 3 months' time, Yaku will be able to type in Yaku Stokes, National Department of Health, and he'll have a live feed to all those dashboards that are currently available. He can drop and drag products, he can look at different provinces, he can see where the shortages are. So we're going to move from that static type environment to a much more live environment. Like I said, different data sources are different levels of maturity, but that's just where we sort of were moving towards. And more importantly, it's not only for Yaku to look at this, it's to disseminate that information to your provinces, to your districts, and your facilities so that everyone is part of the continuous improvement system that you're trying to put in place. Thank you. Great. Yes, we have questions at the back. I don't even.
Questions at the back?
Start with
Yeah,
Stu.
you go on to questions.
Marazzi. Sure.
So thank you very much for the presentations that you offered. I would like to go back to the first piece that you talked about in terms of the essential medicines list.
Yes.
And how a clinician or you're looking at who's looking at specific standard treatment guidelines.
Yep.
And I'm struggling to correlate that with the dashboards that you have right now. So if I'm thinking to the last piece you talked about in terms of predictive analytics, I would assume, let's say I'm in Gauteng province, I'm looking up something to do with hypertension. That data would then be used to feed into some stock management tool somewhere to say that there is an increased spike in patients looking at hypertension, so anticipate more stock there or pre-position stock to plan for this increased demand. Can you talk a little bit about how this data is feeding into the dashboard, because that hasn't come out clearly? Yes.
So I should have done it in silo, because this is an absolutely separate application to all the other performance metrics that we put in place, from suppliers all the way down to the facility. It's just one of the things that we were trying to see here is that when we look at the essential medicines team, they very much concentrate on health technology assessments and rational medicine use. And what they wanted to see is just what are people looking at in specific areas. So for example, you see hypertension, there are 12,000 users. They then drill down and they look at which facilities or where are these people looking at hypertension, right? First line of therapy for hypertension is hydrochlorothiazide. If you look at that facility, they're looking at the guidelines. if we have systems in place like electronic stock management system there, what is actually being dispensed for those patients? Are they dispensing hydrochlorothiazide or are they dispensing enalapril, which is your second line? So it was more from a rational medicine use perspective than the actual monitoring of stock or relation to any of the other dashboards that followed. It was more, this application was specifically developed. This is more of a benefit more than anything else. The main purpose of this tool was to be able to move away from the book system of walking around in a facility with books and having the essential medicine list available to you at a facility.
Okay, thank you for that clarification. I mean, I think I would say that this is actually very powerful data.
Yeah.
That is, I guess, an unintended benefit of how you've digitized your system. That this data can help inform your stock management principles in future.
Correct.
So tying in those data elements together is critical.
Correct.
And maybe, Yaku, you could talk to how the department looks at integrating clinical data together with stock data. Because in many of the countries where I've been, there is always a clear separation of the two and a hesitance in many places to try and put them together. But it looks like here it's sort of within the same system, even though not necessarily in the same database.
Okay. Do you want to go first, and I can just add on to it afterwards? I'll just put up the ICT one.
Okay, so basically, how we link from that point of view in terms of the EDL side of it, and linking that to the supplier side of it. I think the main thing on a clinical from a clinical point of view, taking whatever the essential medicines program come up with will inform whatever is on the contract and on the tender. Okay, and then basically managing that from a supplier point of view in terms of post-contract award. Okay, looking at those specific items, looking at the uptake of those specific items, and then where there's any problems that we experience in terms of that. Okay, is to try and ensure that availability of supply for that specific area. If there's been a problem that exists, in various instances, a supplier might experience problems in terms of their supply. Then, from our side, we look at alternative sourcing, international sourcing, that sort of things, to try and establish where we can get that items, and where that items is not available locally. Registered items, then we will follow the route through MCC, try and establish and put in place a Section 21 for that specifically.
Yaku, I just want you to add one thing there for Yaku. So one of the things that we do, like if in South Africa we had, of course, you have a lot of donor funding, and the donor funding is key to antiretrovirals and to TB and to certain disease states. So sometimes what we do have available for certain disease states, for example, TB, is that we have the National Health Laboratory Services, right? We also have ETR, EDR, which monitors the amount of patients that are on TB medication, MDR and XDR. So in those cases, we use that to inform contracting for the tenders specifically. And we also can use that to triangulate and understand how many patients are coming to the facility versus how much stock I'm keeping on hand in the actual facility, the back of the pharmacy. So for certain disease states, it's easier than others. Antiretrovirals also easier. We have lab tests, we have patient numbers at facilities. It gets a bit more trickier for other types of medication. But where we do have data sources available, we will definitely be using that. Yeah. Sorry, did you want to say something?
If you remember the Sheila system that we spoke about, in other words, in future what we plan to do is that we would have a linkage with the NHLS, that we can pull all the data around from the NHLS so that it can inform prescribers what they should be prescribing. In other words, the data when the patient is in front of them, they would electronically be able to see all these results from NHLS, and then afterwards also that we can pull reports and see exactly rational medicine use which prescribers, which areas, what is prescribed, linked to the clinical data that they've obtained.
Question here with Stuart.
Thank you so much. I've heard you say disseminate as you talk about building up your reports, getting up your dashboards, and then disseminating that data down to the lower levels. I'm curious if you could talk a little bit about from the health facility or from the hospital, how are the, say, the DPHOs, the people that are in charge of that hospital, are they using the dashboards and are they beginning to drive their own decision making around this? And maybe it's a part of that future step when they can begin to do these correlations directly in and amongst themselves.
So that's definitely part of the plan. We're not yet there, Stuart, so we're not yet there. But that's part of the plan. Yeah, that is all part of our plan. And it's at the different levels, right? So we can't just go smack bang all the way to the patient level. It will start at provincial, and then we'll move down to our 52 total districts, and then we'll move down to every single facility. So we're not yet there.
Okay, I was going to add on to that then. How are you reaching out to your DPHOs as part of that change management process to engage with them, to build the dashboards that are meaningful to them, that drive their interest level?
Yeah.
Actually, related to that, because my question is also related to that. When you're coming up with the dashboards, there are two approaches you can use. The top-down, where you actually know this is what you should be able to do as at the facility level, at the hospital level. The tools are very simple. You're either going to order or you're going to redistribute. Versus what Yago can do at the national level, he has a big array of things he can actually do all the way from the suppliers. So when you're coming up with the dashboards at the national level, you actually know a lot more about what you want. But is there a bottom-up approach where I could be at the facility, I really don't know a lot about supply chain, and you still want me to do the clinical work? So how do you balance the two between your top-down, that I know this is what you can do and what you should do, versus what you want them to be able to do, and how do you balance the two?
Okay, so let's do all three in one, then I can answer all one time.
I wanted to answer.
Oh, you no, go first, then I'll go.
I think what we're trying to do is we realize is that it's a resource issue. Okay, so to take that professional level of individual and bring him down to facility level, we just don't have enough people. So the intention is to build it down to district level. So we got 52 districts, so it's nice and manageable, each chunk for each 52 districts. Bring the skill levels and the tool sets, because tools are also expensive. Bring it down to that level, and then cut it there and maintain it at that level. And because they're closer to the coalface, their understanding of the coalface, the interaction with their individual stakeholders is a lot better than as you wind it upstream. So you can't, at Yako's level, deal with 4,500 facilities knocking at his door. He doesn't have time a day.
Yeah.
Well, I just want to find out these dashboards. They are actually very good tools to make decisions. However, I can see a lot of stockouts showing, and I discover a particular period where a facility have not reported since April 2016.
Yeah.
What are the process discipline in place for such issues?
Okay, so firstly, it's not real data, it's dummy data. We purposely put those things in there. But I mean, there are some facilities that are not performing well, right? And it's sometimes we first need to find out what the data source is, right? Sometimes if someone's not reporting, it's specifically that source is not speaking to our server, and it's an IT related issue. So it's about the root cause analysis, right? And if it's an IT thing, we get the relevant person in. So if the data is coming through manually, and we're getting it manually from a specific province, it's of course then for Yako's team to contact that province and make sure and understand why is this data not coming in on a weekly basis. They have agreements from national with the provinces that as part of their annual performance plan and the targets that they need to meet, the provinces know exactly what they should be submitting on a weekly or monthly basis. Yeah. So,
Okay.
oh, and we have the director here, so she can also answer as well.
Okay, just to add to what Bashir has said, I mean, for some of the systems, we try to institutionalize that by adding it in as part of the other programs. So, for example, the primary healthcare program with the ideal clinic. So, it's part of the checklists do you have a stock visibility system? Are you reporting? What's your reporting level? And obviously, I'm sure you guys were in the SVS presentation, where the formulary as a denominator then drives your percentage availability. So we're trying to keep that standard, that standard and the definition of that standard constant across all the systems. And even for the electronic stock management systems at the hospital level, they have the CEO of the hospital has it written into his performance agreement. So they have an obligation to report on that and to make sure that they manage that. So that's the way that the department is institutionalizing medicine availability, data reporting at the facility level by including it, as I say, into the checklist and performance agreements with the facilities. So just so that they know that it's not a flash in the pan, it's here to stay.
I'll answer your question now afterwards. I think we have to leave, so I'll maybe just walk with you up and answer your question.
Yeah.
Especially because, I just want to take you through also the difference. We have the historical consumption versus the morbidity models that we use and how we bring that together to, so I'll talk to you afterwards. So if there's any other questions, you're most welcome to catch us in the corridors as well.
Yeah, big
We'll try
round
and
of
answer.
applause for our presenters.